Okay, I hope you got a lot out of that discussion. And it's my opinion that, according to the AMA guides, the activities of daily living is a critical component of our overall opinions and conclusions, either for or against permanent impairment. So let's review just a couple of the basic principles that's important to keep in mind with regards to the activities of daily living assessment. And that is number one, the activities of daily living assessment absolutely, positively, without exception, and there is no argument on this. It must be done in the face-to-face evaluation. So that's number one. And the reason that it has to be done in the face-to-face evaluation is number two. This is number two important thing to remember, is that you, as the evaluating doctor, need to question the examinee about their responses to the activities of daily living assessment questions. You see, it's our job as the evaluating doctors to translate what it is that the examinee tells to us subjectively, uh, to translate that into something that is useful in the workers' compensation system and is useful in using the AMA guides. And many times the examinees will report to us responses on the activities of daily living assessment that are unusable and are actually inaccurate. So it's the doctor's job to question, 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 and question the examinee to come up with responses that are true and accurate representations of the examinee's true condition. And in my opinion, this can only be done. And if you come up with some other better way, well, please let me know. But it's my opinion that this can only be done in the face-to-face evaluation. Okay? So that's probably more than you ever heard or ever wanted to hear on the activities of daily living assessment. So now let's start the next section of this program and move on to some different topics. And let's talk now about deception, symptom magnification, and malingering. And what I want to share with you in this section of the program is going to be fascinating for you. I have some fabulous references and some fabulous material to share with you. And we're even going to get into the AMA guides and find out what the AMA guides have to say about deception, symptom magnification, and malingering. And just to preempt our AMA guides discussion, I just want to go on record as saying I love references from the AMA guides. And the reason is we accept the AMA guides as our tome, T-O-M-E, our tome, and our Bible for procedures involved with examining and evaluating injured workers. And so therefore, if there's a reference in the AMA guides, we pretty much accept the reference as the reference from the AMA guides as a valid, credible, and well-referenced and well-researched reference. So what I want to share with you about malingering from the AMA guides has to be taken seriously because the authors of the AMA guides, in their immaculate and infinite wisdom, chose to include in Chapter 18 some very specific and very unique references to malingering that they want the readers of the AMA Guides 5th edition to be aware of. And so they put it out and published it for all of us to see. And I think it's going to be quite an eye-opener to you when we get to that section of the program. But for now, let's talk about some definitions of these key words that are going to form the basis of this next section of our program. So the first word I want to define for you is the word deception. And we're going to see examinees who attempt to deceive us in some way, shape, or form about one or more issues. We're going to see these examinees in our evaluations. So it's important that we understand and be able to recognize deception when and if it manifests in the qualified medical evaluation. Okay, so according to Merriam-Webster, deception is to cause or accept as true or valid what is false or invalid, to give a false impression. And let me ask you, have you ever had an examinee who you felt was not giving you a totally true impression of their situation and their circumstance? Let me ask you, has that ever happened? That's deception. Now, this may include statements or physical acts. Statements, of course, we would encounter during the interview. Physical acts we would discover during our physical examination. And the purpose of these statements and these physical acts are to propagate beliefs that are not true or perhaps are not the whole truth. This may also include omission or the withholding of information. And this is an area where I want you to be particularly astute and to pay particular attention to, and that is the omission or the withholding of information. And let me tell you a story about this. I once took a home study course. It was authored by a former FBI interrogator. And the title of the program was How to Never Be Lied to, or How Never to Be Lied to, or something like that. And the whole premise of that program was that lies are to be found in the omissions rather than in the commissions. Lies are to be found in omissions and not in commissions. So I want you to pay attention to areas where perhaps your examinee may be withholding information, may be omitting important information, and always ask yourself, always do this litmus test question, and that is, what's missing here? What's missing here? Always ask yourself, what's missing here? It's the omission that may give you important information as to a more accurate situation or a more accurate depiction of the true circumstance. Merriam-Webster defines symptom magnification as the patient exaggerating or magnifying their actual complaints in order to sell the doctor on the truth of their claims. And now it's important in this definition, it's interesting that the examinee has actual complaints. They have actual complaints, but they take those actual complaints and they magnify and exaggerate those complaints in order to sell the doctor on the truth of their claims. Now, I just want to say a couple words about symptom magnification, and that is, after doing qualified medical evaluations for approximately 20 years and doing over 1,500 QME exams, I've come to accept a certain amount of symptom magnification to actually be normal. I consider a certain amount to actually be normal. And if you think about the difficulties of being a claimant, an examinee, a patient, whatever you want to call them, an applicant in the workers' compensation system, if you can imagine the difficulties that these people experience, with difficulties in getting medical treatment, with difficulties in getting their compensation on time, with difficulties that they may be experiencing at the job site, and everywhere you turn, it's difficulties, difficulties, and difficulties. Well, by the time the examinee gets to us at the qualified medical evaluation, they're frustrated, they're angry, they're suffering physically, they're suffering financially. And so they really sometimes can lay on the extent of their suffering, and they can magnify their suffering, the purpose of which is less to deceive us, but more to just convince us that indeed that they have a problem, that indeed they're not getting proper service or proper treatment, and that indeed they are suffering. So in this case, in this situation, a certain amount of symptom magnification is to be accepted as normal. It's when examinees go beyond even this level of symptom magnification, that we need to be concerned. Okay, well, what about malingering? Again, we look to Merriam-Webster. Merriam-Webster says that malingering is defined as to pretend or to exaggerate incapacity or to exaggerate illness or to pretend illness. And it's important, and we're going to see through other definitions, that this pretending and this exaggerating is motivated by external incentives. Some external incentives include, for example, trying to avoid duty, as in military duty, or in trying to avoid work. And these are just a couple of examples of external incentives. And we'll talk about more external incentives here as we go. According to the DSM-4, the Diagnostic and Statistical Manual of Mental Disorders, they define malingering as the intentional production of false or grossly exaggerated physical or psychological symptoms motivated by external incentives such as avoiding military duty, avoiding work, obtaining financial compensation, evading criminal prosecution, or obtaining drugs. And let me ask you, of these, 5 external incentives described by the DSM-4, of these external incentives, which of these external incentives are operative in the workers' compensation setting? What about avoiding military duty? Well, that doesn't actually apply in the workers' compensation setting. What about avoiding work? Certainly that could apply, correct? What about obtaining financial compensation? That's an operative element in the workers' compensation setting. How about evading criminal prosecution? Well, probably not. But what about possibly obtaining drugs? We have many people who are drug seeking and chronic pain patients in the workers' compensation setting are prescribed medications. Is it possible that some of our examinees could malinger for the purpose of obtaining drugs? I would say that it's possible, and it's probable, and it's likely. So of these 5 external incentives described in the DSM-4, at least 3 of those apply to the examinees that we see in the workers' compensation setting. So let's elaborate a little bit more on some concepts associated with malingering. Now, according to the United States military, malingering is a court-martial offense under Article 115 of the Uniform Code of Military Justice. And this code says that any person subject to this chapter who, for the purpose of avoiding work, avoiding duty, or avoiding service, anyone who feigns illness, feigns physical disablement, feigns mental lapse or derangement, or who intentionally self-inflicts injury, again for the purpose of avoiding work, duty, or service, any person that does this shall be punished as a court-martial may direct. So at least this reference, the United States Armed Forces, they consider malingering for the purpose of avoiding work to be a court-martial offense. So a serious punishment for what they consider to be a serious situation, that situation of malingering. So how does malingering manifest in the workers' compensation setting with the examinees that we see? Well, the examinees that we see can malinger with, and this manifests in the form of deliberate and fraudulent feigning of symptoms that aren't actually even there. This is what distinguishes malingering from symptom magnification. With symptom magnification, the examinee has actual symptoms. In malingering, the examinee does not even have actual symptoms. They simply feign those symptoms. And it's important to realize and recognize that the fraudulent feigning of these symptoms is deliberate, it's intentional. So let's complete this definition. It says it's important to understand that with malingering, claims of symptoms, claims of impairment, and claims of disability are willfully, intentionally, and deliberately overstated. It's willful, it's intentional, and it's deliberate, and it has its motive in some sort of external incentive, such as to avoid work, to obtain drugs, or to obtain benefits. Benefits in the form of temporary disability benefits, benefits in the form of medical treatment. Okay, and these are just some examples of some of the external incentives that are operative with malingering. Okay, so let's explore some of the criteria that will help us to be able to identify situations and examinees that may be candidates for malingering. Again, this is according to the DSM-4. They provide for us 4 different criteria, which, if we see any 2 of these criteria present or operative, would give a strong suspicion to the possibility or probability of malingering. So the first criteria is, number 1, a medical legal context of presentation. A medical legal context of presentation. And let me ask you, in the workers' compensation setting, do our examinees present in a medical legal context? Yes. Yes, they do. In fact, we refer to our QME reports as medical legal reports. The workers' compensation system is a medical legal system. And I'll elaborate on this a little bit more as we go. The second criteria is when there is a marked discrepancy between the stated level of disability or impairment and the medical history. The third criteria is a history of lack of cooperation, either with the diagnostic evaluation itself, meaning with your diagnostic evaluation, or with prior prescribed tests and or treatments. And I'll talk about that as well. Finally, the fourth criteria is the presence of either an antisocial personality or the presence of antisocial personality traits. And we'll describe some of those here as we go. Now, according to the DSM-4, the presence of 2 of 4 of the criteria suggests probable malingering. Probable means greater than 51% likelihood. Probable means more likely than not. Now, this is not absolutely definitive, and the DSM-4 has been criticized. However, this should serve to sharpen your, as the evaluator's, thinking to the possibility that malingering is present. And as I alluded to before, in the workers' compensation system, which of the 4 criteria are already most likely present and operative? Well, number 1, a medical legal context, that's likely operative and present. And this becomes even more profound when the examinee is a represented injured worker, represented by an applicant attorney. Now we take a medical legal context and we emphasize the legal nature of the context. It's emphasized by the fact that the examinee has legal representation. What about a marked discrepancy? Marked discrepancy between the stated level of disability and impairment and the medical history. That could be present, and I'll show you how to possibly identify when and if that criteria is present. What about a history of lack of cooperation? That could be present, that could be operative, and I'll show you some examples that would suggest to you that your examinee may be failing to cooperate with the prescribed program. What about an antisocial personality disorder or antisocial personality traits? Well, We'll talk a little bit more about that. And I want you to know that I myself, I'm not a psychologist, a psychologist. However, I have done some study on antisocial personality traits, and I can't tell you how many examinees I've suspected. As I said, I'm not a psychologist, but I've been able to identify some of the antisocial personality traits, which I'll share with you in just a couple moments. So we're going to revisit these DSM-4 criteria in just a minute. But I want to break away from the DSM-4 for just a couple minutes and talk about what the AMA guides have to say about malingering, and this will give us some tremendous insight as we finish up with the DSM-4 and as we explore more of these issues associated with identifying malingering. So let's go now to the AMA guides. Okay, so here we are in the AMA guides. This is in chapter 18, section 18.7. This is on page 585. And let's see what the AMA guides themselves have to say about malingering. And this is fascinating because this section has nothing to do with you or me or my philosophy or our experiences with examinees. This is simply the authors of the AMA guides introducing this topic to us for our awareness and for our consideration. And if you think about the AMA Guides 5th edition, I don't know how many issues of that book have been distributed, but it's probably many. I don't know. I don't want to cite any numbers. But the authors of the AMA Guides printed this book and left it for history. And so here is what they left for history, for us to read and for us to be aware of. It says that malingering is a conscious deception for the purpose of gain, and we already talked about that. That definition is consistent with other sources that we've referenced. They go on to say, while most authorities declare that malingering is quite uncommon, there appear to be few data regarding its frequency. And so there's few data, but there is some data, and here they cite some of the data that they are aware of. So they talk about Fishbane and his group, who reviewed literature suggesting that malingering is present in 1.25%, and that's not a lot, to 10.4% of individuals with chronic pain. So that's not a lot, from 1 in 100 to 1 in 10. However, Fishbane and all found serious flaws with the methodology and concluded that no conclusions could be drawn from the data. Okay, so that's one group of studies. Other fields provide some limits regarding the prevalence of malingering. For example, in individuals with unexplained intractable diarrhea, 14% had positive stool examinations for laxatives, although all had denied the use of laxatives. So let's talk about this one for a moment. These are individuals with unexplained intractable diarrhea. So these are patients that go to the doctor and they report to the doctor that they're having diarrhea. And the doctor says, well, do you have any idea what's the cause of the diarrhea? And the patients themselves, they state or claim that no, they have no idea. It's unexplained intractable diarrhea. So the doctor says, well, what's going on? What's causing you diarrhea? And the patient says, well, I don't know. Well, the doctor says, well, are you using laxatives to explain the diarrhea? And every single one of them denied the use of laxatives, although 14% of them had positive stool examinations for laxatives. This is conscious deception for the purpose of gain. And we might ask ourselves, well, what are these people trying to gain I guess we'd have to read that study in order to find out more of the background about this group of individuals. Another study followed 333 people who claimed compensation, and this is important. They're claiming compensation for noise-induced hearing loss. So, for example, these are people that worked in noisy places and are claiming that they're losing their hearing as a result of working in a factory, working at an airport, or working in other loud places. The incidence of exaggeration on hearing tests was 17.7%, and this was determined by cortical evoked response audiometry, an objective test that measures electrical activity in the parts of the brain that respond to noise and hearing. Okay, so 330 people were tested for their hearing, and so they put tones in these people's ears and asked them, "Do you hear it?" And they said, "No, I don't hear it." And so they turned up the sound and they said, "Do you hear it?" And they said, "Nope, I don't hear it." Meanwhile, the cortical evoked response audiometry testing was indicating that indeed they were hearing the tone. So as many as 17.7%, that's almost 20%, that's almost 1 in 5, exaggerated because they were seeking compensation. Okay? So it suggests that in those situations that involve compensation, incidences of malingering may be higher. Finally, Weintraub cites studies showing that 20 to 46% of people, 20 to 46%, that's 1 in 5 to 46%, that's almost 50%. That's every other person. That's 1 in 2. So Weintraub says that 1 in 5 to as many as 1 in 2 of people consider purposeful misrepresentation of compensation claims to be acceptable behavior. They consider it to be okay. It's okay. There's nothing wrong with purposefully misrepresenting their incapacity or their illness for the purpose of seeking compensation. So I think this series of studies gives us some take-home messages, and this is right from the AMA guides themselves. They tell us that people can malinger, especially those that are seeking compensation. And when they're seeking compensation, there seems to be something that happens to the brain that makes it okay, that makes it acceptable behavior to purposefully misrepresent their symptoms, their incapacity, or their level of illness. So it's important for us as qualified medical evaluators to keep this in mind and to keep this at the top of our consciousness. Okay, so let's now relate this back to the DSM-4. Okay, so now that we have that established from the AMA guides, let's go back to the DSM-4 and talk about some of these 4 criteria quoted by the DSM-4. So again, the medical legal context of presentation, we talked about that. And it's interesting because the workers' compensation setting is not the only setting that involves a medical legal context. What are some other examples of the medical legal context? Well, how about a personal injury case where the injured party is represented by a plaintiff attorney? That would, of course, involve a medical legal context. What about Social Security disability applicants who hire an attorney to help them establish a disability under the Social Security system? That's a medical legal context. So that would be an area that we would suspect could be ripe or rife with examples of malingering. What about Veterans Administration cases where military personnel are seeking disability under the Veterans Administration? So these are just some other examples in addition to the workers' compensation example. What about a marked discrepancy between the stated level of impairment or disability and the history? A marked discrepancy. Always be on the lookout for a marked discrepancy. And let me give you an example from my files of a recent case that I had that suggested to me a marked discrepancy between the mechanism of injury and the history of the case and the level of impairment or disability that the examinee was describing. So in this example, I had approximately a 40-year-old woman. She was doing home health care for an elderly couple in their home. And on this particular day, she got to the home, and the home was quite congested. There were a lot of boxes and debris in all the rooms. And according to this examinee, moving between rooms was difficult, and it required precise foot placement in order to avoid bumping and tripping over boxes and other debris. Well, don't you know, in moving from room to room, she got her feet tangled up in some boxes and fell to the ground. And she landed hard, but she had some x-ray studies, and there were found to be no fractures. She did not hit her head. She suffered basically a contusion injury and a sprain strain type generalized injury where she fell awkwardly to the ground. There were no fractures, and there was no major injury. There was no rotator cuff tear. There was no knee ligamentous disruption. It was basically a sprain strain type contusion / traumatic type of fall. No fractures, no head injury. Well, she had every possible form of conservative treatment, including physical therapy, chiropractic therapy, medication therapy, and the injury seemed to localize itself to the lumbar spine. And she had injection therapy and trigger point injections and facet joint injections. And all this time, she was off work on total temporary disability. Well, by the time I saw her for the qualified medical evaluation, she had been off work on total temporary disability for approximately 22 months. 22 months. Now, in my opinion, I considered that to be a marked discrepancy between the mechanism of injury and the history and the stated level of impairment or disability described by the examinee. And you have to ask yourself, in cases like this, if in the presence of a bona fide injury, such as a slipping and tripping and falling injury, what would be a reasonable period of time for the examinee to recover in the absence of fractures, in the absence of a head injury, in the absence of any significant or identifiable pathology such as a rotator cuff tear, such as an anterior cruciate ligament tear? She didn't have any of those. So what would be a reasonable period of time to expect a good recovery? Would 22 days seem reasonable? 22 days? I don't know. How about twice that? How about 44 days? That's a month and 2 weeks. Would that be a reasonable period of time? How about 2 months? How about 3 months? How about 4 months? She was off work on total temporary disability for 22 months, almost 2 years, and it seemed to me that that was suggestive of a marked discrepancy. And that's just one example. I'm sure you could probably think of examples from your own files. How about a lack of cooperation? Lack of cooperation. Now, the DSM-4 describes lack of cooperation with the diagnostic evaluation, which is your evaluation, and also lack of cooperation with the prescribed diagnostic tests and or medical treatments. So let's talk first about your diagnostic evaluation. How could the examinee demonstrate a lack of cooperation? What would be some examples of lack of cooperation? How about an examinee who shows up to the evaluation late? Perhaps they show up 30 minutes late. Now, what is your deadline, doctor? What is your buffer time that you allow for the examinee to be late? Most doctors allow for up to 30 minutes. What would you do if the examinee showed up 35 minutes late? You'd probably have to reschedule that examinee, and that examinee would then qualify for additional benefits under workers' compensation for an additional 4, 6, 8 weeks, whatever time it takes for you to get them rescheduled and back on the books. How about an examinee who shows to the evaluation without their paperwork completed, requiring you to extend your appointment time another 30 minutes, another 45 minutes, just to accommodate them filling out the paperwork when this is something that they could have done, that they should have done, that you requested them to do on their own time at home and bring to the evaluation their paperwork. That could be another example of lack of cooperation. What about a lack of cooperation with the diagnostic testing and or the prescribed treatment program? How about an examinee who misses physical therapy appointments, attends, every other physical therapy appointment, attends 2 out of 3 physical therapy appointments, who shows up late to physical therapy appointments? How about the examinee who says that they went to 1 physical therapy appointment but they canceled the remaining appointments because the physical therapy made them worse? Have you ever had that situation? Have you ever had an examinee who was prescribed chiropractic treatment and they went to 1 chiropractic treatment and canceled the series of chiropractic treatments because they said the chiropractic treatment made them worse? How about examinees who say that they can't lay in the MRI tube because they have claustrophobia? How about examinees who fail to remain still during X-ray exposures? Now, each one of these situations could happen, but when there's a pattern of recurring lack of cooperation or a pattern of failure to obtain diagnostic quality studies because of examinee factors, that could be a suggestion of lack of cooperation. What about antisocial personality traits? And I don't have all of the antisocial personality traits memorized for you here, but I do remember from the DSM-4 a couple of the antisocial personality traits that relate to us as far as the workers' compensation setting. Now, first of all, the Diagnostic and Statistical Manual of Mental Disorders describes and defines an antisocial personality as a person who has a consistent and persistent disregard for the rights of others. A persistent and consistent disregard for the rights of other people. So these are people who really don't care about others, about the rights of others. Now, one of the most common antisocial personality traits that I have encountered in the workers' compensation setting is what's referred to as social facility. Social facility, F-A-C-I-L-I-T-Y. And facility comes from the word facile. And I think facile, I know it's a Spanish word that means easy. It probably comes from our Greek word. But basically, a person who's socially facile is a person who's at ease socially. They're comfortable in conversation. They're actually quite smooth. They're actually quite flowing. they're actually quite funny. They're quite they're quite charming. It's called social charm. And so people who are socially facile or socially charming, uh, they're fun to interview because they're interactive, they're funny, they're flowing, they're very smooth, they converse very easily and quite smoothly, and they're what's referred to as socially facile. And uh, I've had several of these examinees who were just funny people. Funny people. In fact, I'd love to, quit the evaluation and go and have a beer with them and just chat about sports and politics and all this stuff because they're very conversant, they're great conversationalists, and they're funny. They're fun to be with. And that is the socially facile person. So when you identify a socially facile personality, that does not necessarily indicate that that person is a malingerer, but it could. It could. And that's all we're saying is that it could. Remember that the DSM-4 says the presence of any two of these four is a strong indicator of probable versus possible malingering.